Hello. Okay. Hello. Hello. Can you hear me? Hello. Okay. Can you hear me, Carol? I can hear. I don't know why. Okay. 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 Share desktop. Maybe this is my slide. Mm, just one second. Okay, it's working. Okay. Yes. I just want to see just one video. I want to see sure that the video is working. Okay. I will skip to the video just to be sure the video is working. Okay. Mm, mm, Stop share. Okay. Okay. Okay.
Great. Thank you. Tá ouvindo?
Yeah, we are.
Okay. Can you listen to me? Can you hear me?
Yes.
Great.
Good to
Okay.
see
Today,
you.
good to see you too. I'm in the hospital right now. So, is Pablo around?
Yes, he has just tested his slides and he's ready to start. We will be starting
Okay.
in a few minutes.
All right. Okay. You feel free to introduce him if you want. Okay.
Okay,
I'll be around. I'll be here.
great.
And I have to leave around 2 p.m. because of the outpatient clinic.
Okay.
But I will follow. I will see his presentation. Okay.
Mm-hmm.
All right. Wonderful.
Great.
So you
Thank you.
okay. Thanks. I will mute myself. Okay.
Hey, Pablo. ¿Qué tal?
Hello, Gwen. ¿Cómo estás?
Hello,
Bien.
how are you? Good to
Fine,
see you.
fine.
Now I'm outdoor. I'm in my hospital,
Wow.
but this is a nice area
Raining.
outdoor. So
Raining.
I'm here. I watched
Okay.
your presentation. Thank you very much for joining us.
Okay, thank you.
Muchas
Thank
gracias.
Por favor, gracias a vos y a Caro.
Okay. Carolina is the boss, okay? I'll
Okay.
just watch. All right. She's always the boss. Okay, I'll wait here.
Okay,
Kind
all
of
right.
windy here. Yeah, I lost my mask. Okay, now I'm back. Good to
1
see-
minute to go.
Okay, wonderful.
How long? How minute?
1 minute to go.
Okay.
Yeah,
Maybe
I think it's time.
it's time.
Whenever you want, guys.
Okay.
Wherever you want. No problem.
Okay, so
Ready?
let's start. It is Friday. It is the last Friday of the month of February, and we are back with the meeting for the brain lovers at the World Federation Rhoton Anatomy. And we are very pleased to welcome Dr. Pablo Rubino, who is our longtime friend. And Dr. Wayne is also with us today. He's waving to everyone. And we are ready to start whenever you are, Pablo.
Okay. Let me share my. Can you hear me?
Yes,
Okay.
we can hear you well.
Okay.
I'm sure
Then-
everyone knows that you are a very experienced neurosurgeon in Buenos Aires, and we are all very anxious to hear you talk about the aneurysms, the surgical, anatomical, and angiographical correlations of the carotid aneurysms.
Let me.
Take your time.
Yes, I am looking for my presentation. It was just a few. No, sorry.
No problem. We have time. And I was saying that you are going to talk about carotid aneurysms, and if we go like that, it's a long topic, right? But I believe you are going to speak about the paraclinoid aneurysms, if I'm not wrong, which
Okay.
is your specialty.
Okay.
We see you well.
Okay. I will give some. I will show some cases of paraclinium, but you will see. Okay.
Okay.
Um, okay. First, thank you, Carolina. Thank you, Dr. Wen, for the invitation to talk. It's as usual, it's a great honor for me to be part of this team, anatomy team. So I'm going to talk about the anatomy and geography and surgical correlation of internal carotid artery aneurysm. These are my two places that I work most. One is Hospital Alemán on the left, on the right is Hospital El Cruce, and these are the main places for me. Let's start with the message that we can say that the anatomy has several meanings. Today I would say the anatomy, one of the meaning of anatomy is versatility. What versatility means? Versatility is to have a wide variety of skill, and this versatility, I can be sure that it we can get so many surgical resources, and if we have many surgical resources, we can perform a tailored surgery for our patient, and all of these tailored surgery can be performed because we know microsurgical anatomy. Okay, when we are describing the anterior circulation, especially internal carotid artery, I always like to start with the case just to emphasize what important is the anatomy. Okay, so this is AP projection of 3D reconstruction of digital angiography. You can see here a giant ophthalmic aneurysm. This is one type that we call the through ophthalmic aneurysm. So this is the aneurysm that is always intradural. So this is a good example of internal carotid artery aneurysm. The patient came to our clinic with some severe visual deficit. So if we know anatomy, we know that we have to do a pterional approach or something similar. We have to know when we should open the cilium fissure in order to expose the distal part of the artery, the proximal part. You also need to know anatomy, in this case, to remove the anterior clinoid process in order to expose much better the neck of the aneurysm, and at the same time, you can expose the clinoidal segment of internal carotid artery to have a proximal contour. And finally, you can clip and resolve this case. Why? Because you apply the anatomy you learn in the lab. Regarding anterior circulation, following our master, Professor Rhoton, I like to describe from the proximal to distal part. It's very useful to use angiography to compare. So we can compare anatomy, angiography, and then why we need to know this anatomy. And we also need to know the normal anatomy, but at the same time, the anatomical variant that the patient can offer us. So it's important to know the anatomy. So the first segment, as you can see in this picture, is the segment that we call cervical segment of internal carotid artery, which starts at the level of the fourth cervical vertebra, where the common carotid artery bifurcates into two major branches. One is external carotid artery, and the other one is the artery that is today is our topic, is the internal carotid artery, the cervical position, or the cervical portion, okay? This is now in a larger view. This is the portion of the internal carotid artery, the cervical portion. We should know, I think that two or three things that are important. First, first thing, there is no collateral branches in the cervical portion. Another thing that the cervical portion of internal carotid artery just medial and deep to the sternocleido muscle. And here I have another dissection. You will see that this artery, as you watch in the angiography, just go just in front of the spine, medial to the internal jugular vein, and just posterior to the internal carotid artery. We also find this very important structure, which is the vagus nerve. Okay, so with this anatomy, why we need this anatomy? Because sometimes we need to deal with some lesion at this level or in the supraclinoid segment of internal carotid artery. So we need to expose the carotid artery in the cervical portion to treat aneurysm, to do cervical endarterectomy. You can also need to perform a high flow bypass, or in case you need to do some maneuvers like suction, retrograde decompression of a giant aneurysm. Also, there is a room for one more indication, which is a vascular tumor, like this one. This is a carotid glomus tumor. So we also need to expose and know the anatomy of the cervical portion of internal carotid artery. This is after removing the tumor. Then we have the second segment, and you can see here in this angiography, once again, it's very useful to use the angiography with anatomy. You can see this triangular shape here that belong to the Petrous portion of the temporal bone. And this is the second portion of internal carotid artery that we call Petrous segment of internal carotid artery, which is inside of the temporal bone. And in this bone, the artery describe a canal that we call carotid canal, okay? We can recognize in this in the Petrous portion two segments. The shorter one is the vertical segment. There is not so many structure related with this portion, and the second portion is the horizontal portion, which is in very close relation with the trigeminal nerve. So when we are dealing with some tumor in this area, we should keep in mind that the internal carotid artery in the Petrous portion, the horizontal portion, is very close to the trigeminal nerve, and we also need to know this anatomy when we are dealing with apex, Petrous apex tumor, so you can drill lateral or medial to the internal carotid artery, but always remember the position of the artery just below of the V3, ram of the trigeminal nerve. Then, as you can see in the picture, the artery just go under this ligament that we call petrolingual ligament, and the internal carotid artery enters in this very complex structure, which is the cavernous sinus. Inside the cavernous sinus, we can recognize a different segment of the internal carotid artery, and this segment are the posterior vein, sorry, the posterior ascending segment, then we have the posterior vein, the horizontal segment, the anterior vein, and finally, the anterior ascending segment. I put in a different color because it's a controversial point. For anatomical point of view, we can consider this segment as outside of the cavernous sinus, but it's not in the intradural space. So it is a different segment by itself that we call clinoidal segment of internal carotid artery. Because this segment is not in the cavernous sinus, it's not in the intradural space, but this is from a strict anatomical point of view, but for surgical point of view, we can consider it as a part of the cavernous sinus because when we are dealing, we are with a paraclinal aneurysm, and we need to open the distal and proximal ring. We can observe a vigorous bleeding coming from the cavernous sinus, but just to know that the anterior ascending segment we can also call clinoidal segment because it's in very close relation with this structure that we call clinoid, anterior clinoidal process. So this is the segment that we call clinoidal segment of internal carotid artery, and here is in between the two dural ring, the proximal dural ring and the distal dural ring. It's important just a few words regarding the anterior clinoid process. Just remember that this is the posterior and medial projection of the lesser sphenoidal wing. There are some anatomical details that I think that are very important. One of them is the attachment to the skull base. Remember that the anterior clinoid process has three attachments. One is the lesser sphenoidal wing. The second one is the roof of the optic canal. And the third attachment, maybe at least for me, the most important, is the optic strut. And if you see from anterior, the optic strut is this structure, is the anterior and the posterior and medial attachment to the skull base from the clinoidal process, and is at the same time is the inferior and lateral limit of the optic canal. So it's in very close relation with the optic nerve and the ophthalmic artery. At the same time, the optic strut is the superior and medial limit of the superior orbital fissure. So it's in very close relation with the nerve, especially with the oculomotor nerve entering the orbit. So this is the anatomy we need to know. We need to know that when we are drilling this structure, what structure we have above, we have below, and especially in this case, what structure we have behind. So just behind the optic strut, we can find the clinoid segment of internal carotid artery. So it's very important when you are drilling, be extremely careful regarding this structure. Then you have to know that there is two rings, especially the proximal dural ring and distal dural ring. The distal one is the ring that is very tight to the carotid artery in 360 degrees, and this is the ring we need to open in order to expose the clinoidal segment in case we have to deal with some paraclinoid aneurysm in order to have better exposure of the neck, in order to have a proximal control, or even though in some cases where the aneurysm is intra and extradural, we need to open widely all of these areas. So we need to know this anatomy in case we need to treat this aneurysm. Here, just a picture of a typical ophthalmic aneurysm, we call through ophthalmic, which is the aneurysm is pointing in superior projection. This is always intradural, and many times you can do it intra or extradurally. You can or not remove the anterior clinoid process. So once again, we are here now with this anatomy. So this is this red circle is showing us maybe the limit of the carotid, or the limit of the beginning of the supraclinoid internal carotid artery, which is maybe the topic for today. And it's typical here to recognize three different segments. The first is the ophthalmic segment, from the origin of the ophthalmic artery until the origin of the P-cone artery, as you can see here. Maybe this is the largest segment of the internal carotid, the supraclinoidal segment of internal carotid artery. Then we have the second segment, which is the communicating segment, that is from the origin of the P-cone artery to the choroidal artery. This is maybe the shortest one. And finally, the choroidal segment of the supraclinoidal artery, where the limits are the beginning of the origin of the anterior choroidal artery until the carotid bifurcation. We can also include the crotch of the origin of MCA and A1 at the level of the carotid bifurcation as a part of internal carotid artery, and already prepares an example to show, okay? This is the view. You can see that after passing the distal dural ring, the internal carotid artery, the supraclinoid segment, goes from medial to lateral, from anterior to posterior, and from inferior to superior, just to bifurcate into two major branches, which are the largest one, the lateral, is MCA, and the medial one, and anterior, is the ACA or A1, okay? So after passing this distal dural ring, this is the supraclinoid segment of internal carotid artery, okay? Here we can recognize the segment that I show you in the angiography. This is the first segment, ophthalmic segment. Then we have, we find the communicating segment, choroidal segment, and finally the crotch of the origin of A1 and MCA. So it's important when we are, as I told you before, to know the anatomy to apply in different pathologies, okay? Let's start with the first segment, and in each segment, I'll show you now, okay? You can see different segments. So you have a segment and you have the artery. The anatomy, the information you need to know is where the artery arises, and what about perforating or branches from this segment and from this artery. So the first segment is the ophthalmic segment. You can see that the ophthalmic artery, this is like an endoscopic view, arrive from the superomedial, most frequently from the medial aspect of the internal carotid artery, in the intradural space in 92% of the cases, okay? Then after arising from internal carotid artery, ophthalmic artery goes just below the optic nerve and goes laterally in order to reach the orbit. You can see here in the lateral projection like a bayonet configuration of the ophthalmic artery. This is showing us the intradural space most of the time, because, as I told you before, 92% of the cases, the ophthalmic artery arrives from the intradural space a few millimeters distal to the distal dural ring. But sometimes we should pay attention, as you can see here, the ophthalmic artery can arise from the cavernous sinus or from the clinoidal segment, even can enter to the orbit through the superior orbital fissure. So it's important to know the normal anatomy and taking into account some anatomical variation that we can find in a patient. So as I told you, the ophthalmic artery then goes lateral below the optic nerve to enter in the orbit after 1 centimeter, divides into several branches to the structure in the orbit, maybe another class we can describe. Another important thing is regarding perforating branches. We should know the segment and the artery. The ophthalmic artery is very uncommon to give perforating branches. It's more common to find perforating branches, in average 4 perforating branches from the ophthalmic segment. And most of these branches, as you can see in this picture, arrive from the medial aspect of the internal carotid artery and goes medially and superiorly to reach the pituitary stalk, the pituitary gland, and the optic chiasm. So, and the biggest one of these arteries are named superior epiphyseal artery. So we need to know how many arteries we can find for, the projection, and where we can find the perforating when we are dealing with some kind of aneurysm, like this one. This is a medial one, previously coiled aneurysm. So if we know anatomy, we should know that this an aneurysm can compromise some perforating branches from the medial side, so we can go from contralateral side, so we can use the anatomy to treat this patient, and we cure with clipping this previously coiled aneurysm. Then we have the second segment that we call a communicating segment, maybe the shortest one of the segment. Here, similar to the previous one, we have the Picon artery and the Picon segment, okay? So we need to know, this is the normal anatomy, we need to know the anatomical variant that we can find here. You can see this is a picture from inferior view. Most of the time, the Picon arrive from the posterior aspect of the internal carotid artery and have a posterior and medial projection in order to join the P1 segment of the posterior cerebral artery, okay? So it's important to know perforating branches and anatomical variants. So this is another dissection just from above. We can recognize 2 clear segments of the Picon artery. So we have an anterior half and a posterior half. As you can see in both sides, that the anterior half has, most of the time, we can find in average 4 or 5 perforating branches. These branches, we should know that most of the branches are in the anterior half. The posterior half, most of the time, is free of perforating branches. These perforating branches arise from the superior aspect of the Picon. They go to the floor of the third ventricle, to the posterior perforated substance, and irrigate the internal capsule, thalamus, and other structures. So this information is useful for us because when we are dealing with some aneurysm, we need to know the normal and the variant. Here, this angiography, where we are here, and you can see that this is a large Picon artery. This is the anatomical variant that is very common. Maybe we can find even in 20% of the cases unilaterally. And this is the variant that we call a fetal configuration of the Picon. You can see in the left side, the irrigation from P1 belongs to the Picon artery instead of posterior cerebral artery. This is the way that we call fetal configuration. It's important. Why is important? Because it's more associated with, as you can see in the specimen here, with Picon aneurysm. And sometimes when you are dealing with some aneurysm, Picon, like this one, it's mandatory not only to clip the aneurysm, but also to preserve the Picon artery if you want to avoid a disaster in the post-op with the patient. We have a very important ischemic lesion after clipping if you don't respect the fetal PCOM. This is the case. Unfortunately, we could. Another variant here is not so clear, but at the beginning, at the origin of the internal carotid arteries, many times we can see a dilatation of the PCOM that we call infundibular variant. And it's important to take into account that it's not a real aneurysm. It's not, the configuration is not so clear, but you can see that at the tip of the infundibulum, we can see the PCOM artery. So it's important to know this anatomical variant we can find in 6% of the patient. You don't need to treat it. It's not a problem. Just it's something, this is variant of the patient. Regarding one more anatomical detail that is important, as I told you before, you said the first half, we can find at least 4 perforating branches, and the second half, most of the time, are free of perforating branches. This is important because when we are dealing with, for instance, this basilar tip aneurysm, we want to expose much better, maybe we need some more room, we can cut the PCOM artery, as you can see here. This is PCOM, internal carotid artery, so the second half, near to P1, we can coagulate and cut, so we have more room now to put a clip and treat basilar aneurysm. So two conditions. First, check for the segment is really without perforating branches, and second, it's impossible to do in case we have a fetal configuration of PCOM. Then we can go for the most distal segment of the supraclinoid that we call choroidal segment of internal carotid artery. And there, the origin is the choroidal artery until the carotid bifurcation. And here, the most important structure is obviously the anterior choroidal artery. And you can see here, we can recognize two clear segments. One is the largest one, which is the cisternal segment of the anterior choroidal artery, and the second is the plexual segment of internal carotid artery. Both segments obviously are important, but the most important, at least for me, especially for aneurysm surgery, is the first segment, even the first half of the cisternal segment, and we can find, and you can see now, at least 4 perforating branches, not only from the segment, but also and especially from the choroidal artery. And this branch, as I told you before, you should know where you can find the branch in the superior aspect of the artery and where these branches are going. Most of the branches go to the floor of the third ventricle, can go to the anterior perforated substance, and some of them can go to the ancus. And the second half entering the inferior choroidal pone of the choroidal fissure to make many anastomosis with branches of the posterior and lateral choroidal artery that belong to the PCA. Okay, so this is the anatomy we need to know to apply. And remember that when we are dealing with some carotid aneurysm, if you are opening the cilium fissure from lateral to medial, you will always see, and you must check, no matter you are dealing with a PCOM aneurysm like this, you always check for the origin of anterior choroidal artery, because sometimes it's very close, just a few millimeters distal to the PCOM. So we need to take keep in mind this artery to preserve, because if you include in the clipping, could be extremely dangerous and very bad for the patient and for you as a surgeon, of course. And finally, we have the crutch that belong to the origin of both A1 or MCA. And this is the site of a carotid bifurcation aneurysm. And here, once again, the use of the anatomy is very useful. Remember, this is another place that we can deal with many perforating branches that arise from this segment, or perforating branches that came from PCOM or choroidal artery very close to the aneurysmal wall, and especially this artery, the recurrent artery, so Horner, that is most of the time very close and is stick to the posterior wall of carotid bifurcation aneurysm. So you need to preserve and dissect if you want to avoid some neurological deficit in the post-op. And here you can see this is AP projection. You can see many perforating branches that are arising and very close to the carotid bifurcation. So keep in mind, and this make a very challenging aneurysm to treat for us because here in the right side, I enlarge the view, you can see that many times you have to deal with 3, 4, or 5 perforating branches before clipping. So it's very important to know, to have this information. Another information that I consider very important is the large of the supraclinoid segment. You can see on the left side, this is a very large supraclinoid segment of internal carotid artery. I'm sorry. And on the right side, very short. And this is important because if you have a large segment and you have to deal with carotid bifurcation aneurysm, maybe you need to change your approach. Maybe you need to do some more scale-based approach like OC or something like that. But in this case, you have a short one. Maybe you don't need with just a common terminal approach or mini terminal approach. Maybe you can reach and treat this kind of lesion. Finally, the internal carotid artery, just below the anterior perforate substance, medial to the lateral to the optic chiasma optic tract, bifurcate into two major branches. The lateral one is MCA, and the medial one is anterior cerebral artery. Obviously, this is not the topic for this talk, so maybe could be for another talk from other expert. Okay, so now just let's go from how we can apply this anatomy to treat some internal carotid artery aneurysm. I will include here only aneurysms that are distal or yes, distal to the distal dural ring. So I mean aneurysms that are in the intradural space. These are the true ophthalmic aneurysm, Picon aneurysm, anterior choroidal aneurysm, and finally carotid bifurcation. All of these aneurysms are considered that compromise or are in very close relation with the supraclinoid segment of internal carotid artery. Remember just the dissection I showed at the beginning. Why I include only the superior projection of a paraclinic aneurysm that we call through ophthalmic aneurysm, because it's 100% of the cases is an intradural aneurysm. The inferior one could be partially intra or extradurally. Even the medial one can also be considered part of the intra or extradural portion. So this is the only one which is 100% of the cases intradural. Okay. Regarding aneurysm treatment, for me is I think that if we can follow this 4-step, I mean, proximal control, 360-degree dissection of the sac, preservation of the perforating branches, and keep free the proximal and distal artery to the aneurysm sac. If you can do all of these steps in a very clean surgical field with delicate maneuvers, I can say that the success is guaranteed, maybe 99% guaranteed that you will have a success in your surgery and you can exclude the aneurysm without any problem, okay? I just want to show different cases to know that how we can apply the anatomy. This is the superior projection of ophthalmic aneurysm, you can see. Most of the time, this is very not so difficult aneurysm. And in 20% of my cases, I don't need to remove the anterior clinoid process, especially in this case, there is no history of SIH, just a regular teleonal approach with opening the Sylvian fissure from lateral to medial, from superficial to the deepest part of the cilium fissure. Then you will reach the carotid cistern. I will skip some step. Pay attention. I am doing passive retraction with the suction tip. In this case, I don't need the spatula, but in case I need, no problem. If I remove and release CSF, so I have a relaxed brain. So here, the only maneuver that I did was just with the Carrison, just remove a very small part of the optic canal. I have enough room now. I can see here the origin of ophthalmic artery, aneurysm neck. Just put the dissector. So I have a 360, almost 360-degree dissection of the neck. No perforating branches involved. Proximal control if I need, and just put a clip. Then control with Doppler. And after clipping, I always coagulate and perforate the aneurysm sac to be safer that the clip was okay. Simple surgery. Less than 30 minutes, the intradural time, most of the time for this case. Then we can go to a very similar example, but in this case with the mini-terminal approach. Most of the time I prefer the regular standard terminal approach, but just to know that if you know anatomy, you can apply your anatomy, you can do different time according to the patient case, okay? Just the same that the case before, open the cilium fissure, go from medially. In this case, that's the only difference with the previous cases, it was a mini-terminal approach. I just cut in the falciform dura, and then with the Carrison, just a very small part of the orbit roof of the optic canal, and just put a clip similar to the previous one. Sometimes here you can see I will preserve the clinic process. Not necessary. You don't need to remove some cases, so you need to tailor your approach. Here another example is a quite large ophthalmic aneurysm, another through ophthalmic. Why through? Because it's a superior projection. So I start with the terminal approach. I will skip some part in order to show some more cases. Just go deeper, open the carotid cistern. You can see the optic nerve is with compression of this large aneurysm. So I know that you want to see a much better proximal control exposure of the aneurysm. I need to remove the anterior clinoid process. So I just put a retractor after release CSF. I usually make two cuts, one medial to the optic nerve, the second in the at the level of the lesser sphenoidal wing. Then I remove the dura, covering the clinoid process. And this is a very important step. With the dissector, I just try to identify the inferior border of the anterior clinoid process. And I know that just below this inferior border, I have the proximal dural ring, and I have the oculomotor nerve. So I start my drilling now I make two cuts, one medial to the optic nerve, another from lateral to medial, and many times I am putting dissector because I know that just below my drill, we can find the oculomotor nerve. And the final point of my dissection is this structure, which is the optic strut. Remember, just posterior is the clinoid segment of the internal carotid artery, and inferior the oculomotor nerve. So now I am removing in one piece, and then I complete the opening of the distal dural ring. I put a clip. After clipping, I check that there is a remnant of neck in the posterior part. What's the problem? The problem is that I didn't follow one of the steps, which is 360-degree exposure of the sac. So I just remove the clip. I complete a larger opening of the distal dural ring. You can see some bleeding coming from the cavernous sinus. You can put fibrin glue. in order to stop the bleeding. And now I had much better dissection of the neck. And I can put the same clip, but you can see now there is no remnant of the aneurysm, and the aneurysm is already clipped. Then I check with Doppler, with bipolar, and perforate. And this is the final view. This is the post-op control. Patient did very well. So we are increasing, or we are showing our versatility to treat. Some author, some surgeons prefer to do extradurally. I usually do extradural, especially for tumor, but for vascular, I do both, but most of the time I do intradurally. But the anatomy is the same. The three attachments of the clinoid process are the same. This is another ophthalmic aneurysm. So we did the pterional approach, but in this case, you can go extradurally. You can drill the lateral wall of the orbit. Then you can recognize the periorbit, and here the dura of the temporal lobe. So we identify the meningo-orbitary band. We can cut the band, and we can complete like a mini midfossa peeling of the lateral wall of the cavernous sinus. I put some fibrin glue in order to control the bleeding. And then the same anatomy is the same. Just remove the lesser phrenoidal wing, the optic canal, and finally the optic strut. And we can also remove the clinoid process in one piece from extradurally, okay? And then you can check with the Doppler flow of the clinoidal segment of internal carotid artery, and then just opening the dura just in the depth of your surgical field. There is no one advantages of extradural ways. You don't need to open the cilium fissure, just go to the deepest part of your approach, open the dura like a T-shape opening with just the larger one in the cilium, following the cilium fissure, and two more cut, one frontal, other temporal. Just open the cistern, then open the distal dural ring, and you can see here the aneurysm. So just dissecting the distal dural ring and put a clip. And this is another way. If you master anatomy, you can use the different way, because the anatomy, I think, is the same, intra or extradural. This is the post-op control. Sometimes we need some more challenging cases. These cases it's not for maybe a through ophthalmic aneurysm. It's a medial one, but I want to see that sometimes we need to a much better exposure of the clinoidal segment. So I did the extradural way, then I make a midfossa peeling, I remove the clinoidal process, then I enter in the cavernous sinus. I dissect bit ophthalmic oculomotor nerve, B1, and in between them, I identify the cavernous segment of internal carotid arteries. So just to have a proximal control in the cavernous sinus. Then I can open the dura, I remove the clinoid segment. You can see all the clinoid segment of internal carotid artery, and finally, I just put a clip. Just to show that you can use, this is a post-op control, different way. Some, at least for me, more challenging case. This is a giant one. The patient was sent it to me by the endovascular. He couldn't put the flow diverter, so he asked me for a treat this aneurysm. Always I try to, I think that the clip is the best, but in some cases, maybe we need to make it to prepare some high flow bypass. So we complete the pterional approach. We took the radial artery as a graft. We complete the pterional approach. Then we move to the neck to expose the cervical carotid artery. Then we need to open the cilium fissure in order to identify the M2 segment. Most of the time, I choose the temporal branch to perform a bypass. So we did the anastomosis at the level of the M2 segment. Then after complete the first anastomosis, we check that is quite well. Just go to the neck. So as I told you at the beginning, it's important to know the anatomy of the neck, and we complete the second anastomosis at the level of the cervical portion of the carotid artery. In this case, external carotid artery. Okay. So these are the resources that the anatomy give us to treat this kind of aneurysms. This is a post control. This is control 2-3 alerted. The aneurysm is gone, and the bypass is still patent. Okay. And then we can deal with aneurysm to the different segment that we call PCON, choroidal segment, and carotid bifurcation. Regarding this aneurysm, I think that PCON, we can have a different projection. We can find lateral projection like this. I think, at least in my practice, is the most common projection of PCON aneurysm, very close to the oculomotor nerve, to the ankles of the temporal lobe. So be careful with this maneuver of retraction and this region. We can also deal, at least for me, the most difficult PCON variant, which is the posterior one, because difficult to clip, difficult to deal with many perforating branches from PCON and from the communicating segments that are not so frequent. But you can deal, you have to deal with most of these perforating branches. And another atypical variant, maybe just less than 5 cases in my practice, the medial projection of a PCON aneurysm. This medial, lateral, posterior could be applied for choroidal aneurysm. And finally, we have to deal with aneurysm in the carotid bifurcation. And the most common variant, at least in my practice, are the anterior projection one. It's not the most common. The most common is the superior projection one, with the most difficult part is the posterior wall, but it's many times very close to the perforating branches, and the worst variant, which is the posterior projection, or posterior projection, of course, of the carotid bifurcation aneurysm. So I want to share with you some of these cases. This is a typical one, the lateral projection of PCON. And just want to show this. This patient also have a fetal configuration of PCON aneurysm. So we did the teleonal approach. We start opening the cilium fissure from lateral to medial, where at the level of the pars triangularis. This is the best place to start the opening because it's the maximal separation between the frontal and temporal lobe. And we usually go forward and deeper until we communicate the cilium fissure with the carotid cistern. I will skip some part. So now you can see internal carotid artery, the origin of fetal configuration has become. I just put the dissector. I love this dissector. It's a teardrop 40 degree. I just put in the proximal part of the neck, distal part of the neck. As much as I can see here, no perforating branches. I love this side curve clip for clipping this kind of aneurysm. So I am sure that I am respecting the PCON artery. And after clipping, the job is not completed. We need to check always the length of the clip. We need to check that there are no perforating branches, there are no neural structure involved in the by the clipping. Okay, and here after dissecting, I can be sure now. I will cut just part of the aneurysm just to be sure that there is no perforating branches involved. The aneurysm is very well clipped and no compromise of the oculomotor nerve. You can see perforating branches, as I told you before. It's mandatory to respect all of them. I put just one more clip to be much safer, okay? This is control. The same from left side. similar to the previous one, pterygiumnal approach, opening. This is another with lateral projection, just to show no retraction, at least at the beginning. Maybe sometimes for clipping to have some more room, I can use a retractor, but here, that I told you before, the basic step, proximal control, 300C dissection of the neck, no perforating branches involved in our dissection. Just a few millimeters distal to the PCOM, identify the anterior choroidal artery, because it would be very dangerous if you include in the clipping. I am completing the dissection here. Just put the dissector and put the clip, and then check. How you can see that the aneurysm was very close to the ancus. Be careful in case that you have a SIH. And then check. No perforating branches here involving the clipping. Very important. And this is the origin of a PCOM. One more case with the fetal configuration of PCOM. You can do it by a mini-pterygiumnal approach. I will skip this case. Maybe we need to show some more cases. Regarding the posterior variant of PCOM, I think this for me is the most difficult one. This is a patient came to our hospital. He came with the SIH in a regular condition, but the brain is not so bad. So we start our dissection as usually from lateral to medial. Just let's go to the aneurysm. You can see here, 1, 2, 3 perforating branches, all of them very close to the wall of the aneurysm on the medial side. So we need to dissect medial side, we need to dissect the lateral side. We have to check the origin of PCOM. So for me, it was very difficult, very challenging case. We need to dissect all the aneurysm. We have enough room for a proximal control. I will skip some part, and then most of the time we need to clip with a fenestrated clip in order to avoid stenosis of the aneurysm. This is the clipping, and then we need not only to check the clipping, but also from above the bifurcation, we can check that there is no perforating branches involving our clipping. You can see 1, 2, 3 here. And you just perforate the aneurysm to be sure the clipping was okay. And we complete with some more clip in the posterior part. This is the post-op control. Then let's move to the choroidal exome. This is a case that we operated in our hospital just before with patient with have SIH on the right side. So on the left side, patient have 3 more aneurysms, P2, choroidal 1, and MCA. So we did a mini-pterygiumnal approach. We opened the cilium fissure. Here is, by the time, our chief of residence, Dr. Herrera, was doing the surgery at the beginning. So we expose cilium fissure. We connect the cilium fissure with the carotid cistern. You can see this is anterior choroidal aneurysm. This is here, PCOM, anterior choroidal artery. Sometimes can be a duplicate origin, so we should be careful. Here you can see 1 and 2. It's not perforating branches. Duplicate origin of anterior choroidal artery. We need to dissect. And just deeper to the choroidal aneurysm, we have some more aneurysm, which is the P2A aneurysm. So we clip this aneurysm first, then we move and clip the choroidal one, and finally we clip the MCA aneurysm. So all of this in one surgery with a mini-pterygiumnal approach. This is the final view. Here, another case with the anterior choroidal aneurysm. Patient, you should say, it's very small, but the patient lost his mother from SIH, so he was very sad, and he said that he didn't want to know that he has a brain aneurysm, but unfortunately he had 4. So we clip first the choroidal one, just similar to the previous one, opening the cilium fissure and expose. Always check, this is perforating branches and this is choroidal artery. Remember that there is a reciprocity rule between choroidal artery and PCOM. If you have a large PCOM, the choroidal artery maybe is not so important, but if you have a strong anterior choroidal artery, maybe this artery irrigate many of the territory that belong to the PCOM. So I complete the dissection of the anterior choroidal artery, then I move to the carotid bifurcation, just posterior and superior. I dissect, and as I told you before, look, 1, 2, 3 perforating branches, one of them very close to the neck, so we need to make some room for clipping, and then we go and clip the choroidal one, and then we move to the MCA, where the patient have two more clips, two more aneurysms. So we clip all of them in one stage. And finally, we have the carotid bifurcation aneurysm. We have the anterior projection, superior projection, and posterior one. I think that the superior projection may be the most common. I clipped right side in this patient 1 year ago, and this aneurysm you can see here was very tiny. And in 1 year, maybe duplicate or triplicate the size. Now it's about 4 millimeters aneurysm, was 1.5 millimeters 1 year ago. So we decide to clip because patient already have SIA from the right side. Similar to the previous one, we open the cilium fissure, try to keep a very clean surgical field, exposed MCA, then the opening of the cilium fissure will carry us to the carotid cistern. Also try to preserve all the veins. Then you can go above the optic nerve, opening the lamina terminalis cisterns. So we are doing room for clipping. I just doing a temporary retraction with the suction tip and sometimes with the retractor. And here I just moving the carotid artery, dissecting the vein. And you will see now, this is the internal the carotid bifurcation aneurysm, superior variant. As I told you many times, you have to deal with the perforating branches that are very close to the wall of the aneurysm. So you need to release these branches in order to have a safer and a very good clip. Then I dissect the vein. So now I have a very good space for clipping. I just put a clip in the superior part and then I check there is no perforating branches involved. This is the final view. This is the posterior one, we have a superior, but with the posterior projection. So we did a sterional approach. The patient has a bleeding, but in very good condition. So we did a transcilium road. We opened the cilium fissure. You will see here that it's quite large, and the reason is inside of the parenchyma, and we need to dissect 300C dissection. Remember, just we have a roof for proximal control. Now we are dissecting the perforating branches. I think this is the most difficult variant. When we have some posterior projection, it's more difficult. You need to dissect and try to find. Maybe you need to do a temporary clipping to relax the aneurysm wall. You can see here perforating branches close to the posterior wall. Then you can go from the other side, and then finally you can put a clip just following the long axis of the aneurysm neck in order to avoid stenosis that can be dangerous for our patient. I just put a clip, I just put a clip, and this is a post-op control. Patient fortunately do very well. And I want to conclude with some cases that all the carotid supracarotid segments involved, as you can see in this large aneurysm. I cannot say ophthalmic, I would say carotid, giant carotid aneurysm. So to do this case, remember, anatomy is very important. So I suggest go to the lab, learn how to open the Cavern fissure, then learn how to do a bypass step, anastomosis. Then you have to complete anastomosis, move to the neck, and know how to dissect the neck, complete anastomosis in the neck, and then go to the OR and do the same with the patient, okay? Similar to the previous case, just take a graph, dissect M2 segment, make an incision at the level of the temporary artery, then check with the micro ruler that you are doing the same signs so you don't have mismatch in your anastomosis. After completed the bypass, then go for the neck, complete the anastomosis at the level of the neck, then move to the intradural space, remove the clinoid process, and just make a trapping, put a clip in the clinoidal segment, and this is the final view how you can treat this case. This is a post-op control, the immediate post-op control, and this is 6 months later. The aneurysm is done, and the bypass is working, and the patient is doing very well. So, as I told at the beginning, to conclude, anatomy means versatility. Versatility means you have many surgical resources. With surgical resources, you can perform tailored and safer surgery for your patient. So you can do many, you have many resources. So, and this is because we can apply our anatomy that we know in the lab. To conclude, as usually, I want to finish with a picture of my two master mentors, I think the giant of two of the most important surgeons of the history, two giants, Professor Evandro and Professor Rhoton. Thank you very much for your attention. Sorry if I take so much time.
It was wonderful, Pablo. Thank you very much. I'm sure both of them, Dr. Rhoton and Professor Evandro, they are very proud of you right now. This is a wonderful talk. I believe Wen wants to say something, maybe if he's still here with us. Wen, go ahead. Unmute. Hey, Wen, would you like to unmute?
Yes,
Go ahead.
but it's not allowing me to.
Yeah, you are. We are listening to you
Oh,
now.
okay. Now, it was a wonderful talk. Pablo is one of the best vascular neurosurgeons in the world for me. So we always learning a lot from him, and he's a very this is the best example of how can we apply the anatomy into the surgery. We go to the lab to learn anatomy, but not just for the sake of anatomy. We learn anatomy because we want to do better surgeries to treat our patients. So Pablo is a wonderful example of what I think about studying anatomy is to apply to the surgery. So this is just to congratulate him. There's nothing else I can add to his wonderful lecture.
Thank you,
so
Wen.
much, Pablo.
Thank you.
Thank you for the invitation. It's an honor. It's a real honor for me to be here with you because maybe I told many times, but I admire so much, both of you, because you are
Thank you.
very,
Thank you.
Thanks.
This is something in Professor
person.
Rhoton school. Everybody admires everybody else because everyone is working very hard and having a lot of work to do. Thank you, Pablo.
Thank
I'm
you.
sure there are a lot of questions and comments. I haven't seen the chat yet, but we are already a little ahead of time. So maybe I ask you, Pablo, to type your email on the chat space.
Okay.
So everyone, if you put your email on the chat space. So everyone that has comments and questions can reach you afterwards because we are not going to be able to reach every question of everyone. Maybe if there is one question or comment, people are always giving you congratulations, saying how wonderful it was your lecture, inspiring work. Yeah, I think everybody agrees about that. And everybody's thanking you and saying great. I myself have a lot of questions. I would love to keep going on this talk, but just to go on the infundibulum. You said infundibulum we don't need to treat. I agree with you, but just to tease a little bit, do we need to follow it up,
Ah,
the
yes,
infundibulum?
yes, we need to follow because could be the beginning of the aneurysm in
Yeah.
some cases. So we need to follow. Even we have some cases in our hospital with a very important SIRH. The only finding was a infundibulum. And in some cases, the patient, because the patient has one more aneurysm, we observe and we just put a wrapping with a clip and dura mater. For I feel more confident if I put just a dura with a clip like a wrapping. But if I see I saw in many in my consult many times I just follow.
Mm-hmm. I agree with you. I think the thing about the vessel coming up from the tip,
Yeah.
sometimes we don't get a good view, and you think it's coming up from the tip, but it's truly coming up from the side, and it's already an aneurysm. I agree with you. That's very tricky.
Yeah.
I don't see any questions around, so maybe it's time for us to close. Thank you so
Thank,
much, Pablo. It was a delight.
thank you, Carolina.
Thank
Thank
you,
you
Pablo.
all. Thank you
Bye.
all. See you next month with Dr. Wen. He's
Oh,
going
me.
to, yes, you will be the next speaker.
Okay. I'm
And
looking forward to it.
would you like to put an invitation for the guys for the course in São Paulo?
Oh,
Would
yeah.
you?
You know, many of us, we want to learn anatomy, but for some reasons, sometimes we don't have a place to dissect. We don't have a lab, and we don't have opportunities the opportunities that I had, Carolina had, Pablo had, a chance to learn anatomy in the lab. And then we are offering courses. We were running courses in several countries. And next month, from March 17th to 21st, we're gonna run the course on the brain's anatomy. So anatomy of the south side gyri ventricles and also the fiber dissection course in São Paulo at the University of São Paulo. It's from March 17th to March 21st. So maybe I don't have it right now, the QR code for registration, but please look it up at International Rhoton Society's Instagram. Everything is all displayed there. So you've had a chance to want to visit São Paulo and also to learn a little bit of anatomy, share information, knowledge with us. Please welcome. And thank you very much. I'll see you guys next month.
Thank you, Wen. Thank you, Pablo, once more. And
Thank you.
thanks everyone who's with us here and also at YouTube. Thank you.
Thanks.